speaker. So thanks to our sponsors, SA3, Discovery, Sapiens, WTW, Ernex, RNA Analytics, Sunlum, Insight, AKUR8, January, MBE Consulting, Fiscal, Liberty, Milliman, Old Mutual, RGA, Swiss Re, Hanover Re, SAL, Colourfield, Africa Re, SA, Communicate Recruitment, Network Finance, and IACA Consulting Actuaries. A few things to note about the exhibition hall. If you haven't done so already, visit the origami tree at the Asset Lounge, fold and design your own origami and hang it on the tree, add your name, and it will enter you into a lucky draw. Secondly, take it to the next level with Sunlam and make sure you enter their lucky draw, and don't forget to stop by RNA Analytics and Ernex to find out what they have in store for this year's convention. Thirdly, if you're looking for the perfect perk meal, go say hi to RGA, who are serving a strong coffee paired with a side of popcorn. A perfect combination. Fourthly, be sure to visit our partners at the ASA Hub, Actuaries Without Frontiers, Actuaries in the Making, Association of South African Black Actuarial Professionals, South African Actuarial Development Program, and Resolve. Lastly, if you need a private meeting space, try one of the meeting pods. Just note they are on a first-come, first-served basis. Also be sure to pick up your parking ticket from the guard room, should you need one. If you purchase tickets for this evening's Centre Court Cocktails Convention social function, I'm getting better at saying that, taking place this evening, please collect your wristband from the information desk outside the exhibition hall. And then now let's talk about the grand finale. I keep calling it the finale, not the final, but I just feel like it needs that level of pizzazz, of the Insight ASA Chess Championship 2025. The finals, the moment we've all been waiting for, will be taking place during this morning's refreshment break. So please go and support. Our refreshment break is brought to you by IACA. Very last thing. We'll be doing Q&A directly after the presentation, so please hold your questions until then. If you don't get the opportunity to ask a question, you can obviously come and engage with the presenter after the presentation, or you can actually engage with them via the app. Okay. Lastly, if you haven't downloaded the app, please do that because it will allow engagement and information to be sent to you directly. Okay, without further ado, please can you welcome Jacob Tenga to the stage for Socioeconomic Determinants and Mental Health Outcomes. Thank you.
Good morning, everyone. Early morning. I'm Jacob, and today I'll be presenting our findings on social determinants shaping mental health service use, a look from 2019 to 2024. So, while clinical care is central to mental health management, it is only one part of the story. Mental health outcomes and decisions to seek treatment are shaped by much more than just diagnosis and symptoms. Factors like income level, job security, living environment, social support, and access to transport services can meaningfully influence whether someone receives timely treatment, delays care, or never accesses care at all. So in other words, mental health is not determined only in hospitals or clinics. It is also shaped by the realities of people's daily lives. So this study examines those broader forces and how they translate into service utilization patterns over time. So before diving into the detail, here's the structure for today's presentation. So first, I'll start with the background and context for this work. Second, I'll walk through the methodology used for this retrospective analysis. Third, I'll share the key research findings on mental health service utilization. Fourth, I will cover the limitations and opportunities identified during the study. And finally, I'll conclude with recommendations that support improved planning, benefit design, and intervention strategies going forward. So, first, what are social determinants of health? So when you talk about social determinants of health, We are referring to the the non-clinical factors that shape people's health outcomes and their ability to access care. Think about things like income, education, and employment. These influence stability, opportunity, and access to basic resources. Then we have living conditions, housing quality, safety, access to services, the environment people live in day to day. These play a big role in stress levels, well-being, and overall quality of life. Location where we stay is also critical. Not just whether services exist, but whether people can actually reach them and receive support when they need the services. Gender also matters because it shapes exposure to certain stressors, experiences of mental health, and how likely someone is to seek help. And finally, something as fundamental as food security. Having consistent access to nutritious food underpins both physical and mental health. So together, these factors create the conditions that either support good health or make it harder for individuals to access help, particularly for mental health needs. So understanding social determinants in mental health is important because ignoring them can lead to underestimating risk or even overestimating risk for some beneficiaries, and also misallocation of resources. Research shows that when we only look at clinical data, we often miss the full picture. For example, individuals facing financial strain, unstable housing, or limited access to care may delay treatment, disengage from care paths, or present later with more severe symptoms. This means that models and planning that exclude social factors can result in poor forecasting, unexpected financial strain, and gaps in service delivery. On the other hand, addressing social factors at a community or scheme level has been shown to support better care management and improve long-term outcomes, especially for chronic and mental health conditions. Ultimately, incorporating social determinants of health, let's call them SDOH, leads to more accurate risk assessment, improved care planning, and better cost management across the healthcare system. And lastly, to explain why understanding these determinants really matter. So when we look at our claims data, we find that mental health care claims have increased by about 11.8% per life per month on an annualized basis from 2019 to 2024. And this is even after standardizing for age, gender, and other demographic factors. And there's the breakdown of the 11.8%. 4.8% of the increase is due to inflation, expected as healthcare costs tend to rise over time. 0.5% is linked to benefit changes made over the period. But what really stands out is the residual increase of 6.6%, which is not explained by inflation, benefit changes, and changes in our membership risk profile. So we believe that while not definitive, it may point to social pressures faced by our members that are influencing mental health care utilization. Like, for example, if a growing population of members is residing in urban areas, that could impact claims experience because access and service is much more better compared to rural areas. So now that we have unpacked as to why we think looking at social determinants of mental health care matters, let's take a look at the data we're going to be working with for the remaining part of the presentation. So our analysis is based on a very stable population base, about 2.4 million beneficiaries. And to explore the impact of these social determinants of health, we have considered several key variables. The first is gender, income level, age band, disease burden, as well as area type. And before diving into the analysis, let's take a moment to just understand part of the epidemiological profile of our population base. So what we have in our data is that about 42% of our total lives reside in metro areas, about 33% in urban areas, and about 26% in rural areas. And if we have a look at the picture on the right, what we see is that approximately a quarter of our total lives have at least one chronic condition. And lastly, if we just look at the salary distribution, what we saw in our data is that the majority of our main members fall within the level 3 to 6 salary range. And now that we've outlined the key determinants and the profile of a membership base, so let's shift our focus to mental health service utilization itself. We look at how lives are accessing care, which disciplines are involved, and what the data tells us about costs and trends over time, all through the lens of these determinants that we've just discussed. So to understand utilization first, we first look at where mental health care providers are located. On the map, we can see a clear concentration of providers in Gauteng and Western Cape, while provinces like the Northern Cape and parts of Mpumalanga have far fewer. And when we adjust for population, shown in the bar chart on the right, the same pattern holds. Gauteng and Western Cape still have the highest providers per 1,000 lives, whereas provinces like Limpopo, Northwest, Mpumalanga, and the Northern Cape show much lower provider density. So even before looking at utilization data, we can see a structural access challenge here. Availability of providers varies significantly by geography, and this has a direct impact on who can seek care. And now that we have considered provider access, we turn to utilization patterns, starting with the distribution of mental health conditions over time from 2019 to 2024. What we see here is that depression and anxiety consistently account for the majority of mental health diagnoses, representing the largest share of claimants across the years. From 2019 to 2024, there's been a steady upward trend, particularly in depression, with a noticeable increase post-2021, maybe reflecting border stress, economic pressure, and post-pandemic effects. Other mental health conditions such as bipolar disorder, ADHD, sleep disorder, and substance-related conditions remain present but at a significantly lower prevalence level. And when we look at mental health claims over time, two dynamics stand out. On the right, we've got the risk-adjusted admission rate, which controls for changes in the member profile over time and therefore reflects a true change in mental health admissions rather than a shift in membership risks. This shows a steady upward trend, increasing from roughly 0.9% in 2019 on an annualized basis to about 1.5% in 2024. On the left, we see a more pronounced shift in spending pattern. The proportion of spend on in-hospital mental health care increases materially from just above 60% to almost 70% in 2024, while outpatient spend declines. So although admission rates are rising at a very gradual rate, the cost burden is shifting much faster towards in-hospital or inpatient care. So this suggests a possible deterioration in case severity, with a growing share of patients requiring more intensive inpatient treatment. And what we have also noted in our data is that over the period, the average length of stay while admitted has gone up by about a day. And that equates to about 14,000 rands per day. So that speaks to maybe the worsening case mix. So when we look at mental health utilization by age and gender, two key patterns emerge. First, utilization increases steadily with age for both males and females, with the highest burden in individuals aged 60 and above. This suggests that older adults are significantly more likely to require mental health support and that mental health needs continue to grow later in life. Second, across most age groups, women consistently show higher utilization rates than men, particularly in the older age groups. And this aligns with global findings where women are more likely to seek care for mental health concerns, while men may face higher stigma or barriers to accessing support. So overall, we see a higher burden among older individuals, and within that group, women are more likely to utilize mental health services than men. So the picture on the right is just a detailed picture of what's on the left. So I picked 2024 as an example to see how utilization really differs for the two cohorts. Here we are looking at mental health utilization across income tiers or income levels of our members. So what stands out is a clear gradient. Higher income members consistently exhibit higher rates of mental health service use, and this pattern holds across all the years shown in the picture. This doesn't necessarily imply greater underlying burden in higher income groups. Instead, it likely reflects differential access and health-seeking behavior. Individuals in higher income brackets are more likely to recognize symptoms, seek care, and afford co-payments as well. Lower income members, conversely may be underutilizing services, which raises equity and access considerations more than prevalence questions. So I guess a joke to take from these pictures that maybe more money, more problems. Here, we look at mental health utilization by chronic disease status and by geography. On the left, we see that members with chronic conditions have significantly higher mental health utilization than those without chronic diseases, about 2 times more likely to claim, across metro, urban, and rural areas. This reinforces the close link between chronic physical health and mental health needs. Also, across all geographies, we see a similar pattern, but overall, metro-based members show a slightly higher utilization, likely reflecting better access to mental health services. However, on the right, we see how provider use differs by location, because you might be asking yourself, why is the prevalence in rural areas like run about the same as what we have in urban and metros? But what we see on the picture on the right is that in rural areas, mental health care is mostly driven by GPs and social workers, reflecting limited specialist availability. So in rural areas, there's a much bigger use for primary healthcare providers. In urban areas, there's a greater access to psychologists and psychiatrists, and this becomes even more pronounced in metro regions, where specialist utilization is the highest. So the takeaway here is that chronic diseases amplifies mental health service use, and access varies meaningfully by geography, with rural members relying more on primary care and community support, social workers, and metro members having greater access to specialist care. So what this slide shows here is mental health admissions across rural, urban, and metro areas. And these figures are risk adjusted as well. That means that the risks are calculated as if the member risk profile was the same across 3 areas for each year, so that the difference is not driven by the difference in the risk profile. So any differences we see here are not because one area is a sicker or older population. Instead, they reflect through differences in admission behavior and access to care. What we observe is a consistent pattern. Metro areas have the highest admission rates, followed by urban and then rural areas. And this trend holds across all the years shown in the picture. So even after adjusting for risk, admissions are rising over time in every setting, which points to increasing mental health demand in our scheme. On the right, what I've shown here is on the right, we also see that 53% of serviced hospital admissions occur in metro areas, compared to 27% in urban and 20% in rural areas. And also, just to point out, importantly, is that rural admissions are predominantly in public facilities, highlighting limited private sector access in those regions. So in summary, even when comparing like-for-like populations, metro members access hospital-based mental health care at higher utilization rates, and rural areas remain more constrained in access. So maybe the question is, are we admitting too quickly in urban areas or metros and not so much in rural areas? Or are those primary healthcare providers that I spoke of in the previous slide being effective in dealing with mental health care at an early age, at an early level? So, almost done. Let me just touch on a few health system gaps that shape how we see mental health utilization. First, the system is still largely geared towards treatment rather than prevention, which means intervention isn't consistently incentivized. Second, we don't routinely collect social risk information, things like housing stability, food security, or transport barriers. So we often rely on proxies rather than directly measuring vulnerability. Third, we have limited qualitative insight into factors like stigma, cultural attitudes, and patient experience, even though we know that those play a major role in whether people seek help. And lastly, claims data only reflects individuals who actually enter the system. So the true level of need is almost certainly higher than what we see in our data. In terms of opportunities going forward, first, there's a clear need to continue addressing mental health awareness and stigma so members feel comfortable seeking healthcare. The second point is about really understanding the rural-urban utilization gap. We saw that, as I mentioned earlier, that even after adjusting for disease burden differences, rural admissions are lower than urban and metro areas. Now, that could mean rural primary care, GPs, nurses, social workers are actually managing mental health care well at a PhD level, or it could mean the opposite, that there are real access barriers and people who should be admitted just can't get in. And on the urban side, it raises question too. Is it a more severe case mix, or are we escalating and admitting quicker than needed? So there's a lot to unpack here, and it really matters for equity and how we resource PAC going forward. So, based on these insights that I've shown, there are several practical steps that can strengthen mental health access and outcomes. First, we can expand mental health capacity by training more GPs and PhD workers to identify and manage common mental health conditions earlier. This helps address the high dependence on specialist care and supports earlier intervention. Second, we need to target specialist strategies in underserved areas, particularly rural provinces, and this may require incentive programs as well. Third, we should leverage digital mental health solutions to scale our reach, including things like telepsychiatry, online therapy, and digital self-management tools. These models can bridge distance, reduce waiting time, and improve continuity of care, even access as well. And finally, there's a strong opportunity to track patient-reported outcomes and experiences, prompts and primes, and to move toward outcomes-based funding models. This shifts focus from service volume to value and real improvement in member well-being. So together, these steps can support earlier access, reduce severity and presentation, and create a more equitable and proactive mental health system. Thank you.
We will now have a time for questions. If you do have a question, please raise your hand and I will get someone to bring a mic to you. So we have here in the front, and then another one here in the front, and then I'll come to you afterwards. Thank you.
Matthew Zolster from Discovery. Thank you very much, Jacob. A very important presentation on the interplay between social determinants of health and the rise of mental health issues. I just wanted to get your thoughts on how we collect more social determinant of health data. I think you did raise it as one of your recommendations and one of your challenges. Typically, as scheme administrators, we collect data that we need to administer a policy, such as those factors that would determine the contributions, but not necessarily more factors that would help with actually addressing some of the social determinant of health issues that we know our members have. And then a second question that I'm particularly fascinated with is how you manage to allocate the members to the metro, urban and rural areas, because we know that the challenges with address data that we have, postal code issues, because a person living in Sandton could be living in Alex, or they could be living in an upmarket apartment in Sandton. So it's very difficult to allocate between kind of rural or underserved areas, even when you've got known addresses, because of the kind of very different lifestyles that exist within certain areas. Thank you.
Yes, thank you. So, with regards to the first question, so you're from Discovery as well. So you guys, I'm sure you also collect data using your wearable devices as well, so that can solve part of the problems. We can also link our population base to, let's take, for example, food insecurity to social deprivation indexes in those areas. So there's so many ways to go about it. I just can't name them all in one go. But anyways, to the second question, so how we went about allocating our members to the urban area metro split. So the first assumption is, it's an assumption, it's not reality or truth, is that your postal code reflects where you actually stay in the membership data. So what we then do is we can link the postal code to your municipality, and we can determine that whether if that municipality is an urban municipality, rural, or so we have about 50 for municipality in the country. So that's not tedious at all. Thank you.
Here in the front. Sorry, the mic here in the front is not working.
Thanks so much, Jacob. That was a great paper. I work actually with Matt, so he kind of stole my question a bit. But we've also had the challenge of just the allocation. I wanted to ask on the urban, metro and rural, was that something that is defined like more broadly, or something that you felt internally to allocate a municipality to like an urban, rural, metro area? And then I guess on that, you were showing there's quite a lot of discrepancies in terms of access to care or utilization between the different areas. And yeah, it's a very hard, like the questions that you asked at the end are so valid. It's hard to know, is it because there's more supply that people are using more, etc. But is there like a ratio of, say, healthcare provider to members that would be ideal? Because, if a place is undersupplied or oversupplied, if there's like a target that you would be looking at. Thank you.
So there is information out there on the internet that shows if whether a municipality is falls under Tshwane, for example. And there's also information out there in the internet that tells you that Tshwane is a metro area. So all we have to do is sort of like take that postal code, which municipality falls under which region. Tshwane, it's a metro, same for eThekwini or whatever, Ekurhuleni. I think with regards to the second question, I think that's more of an exercise that needs to be done, because I can't tell you for sure if, I showed a slide where the density per life is, sort of like by province, it's much higher for other provinces, but does that really say that, okay, the quality of care is much better in that province or not? So I can't say for sure, but I think it's more of an exercise to sort of like engage also with clinical people, what's right, I can't say for sure, sorry.
Thank you.
There was a question in the fourth row.
Okay, Non-Plantler says I can go first. It's Sarah Bennett from MedScheme, and thank you for the paper. I think it raises some interesting questions. My first comment is the graph showing the breakdown of the increases and attributing the so-called residual to social determinants of health. I think there are other factors going on. There's supply-induced demand, and I think maybe you can go to it. So there are, I think maybe a more comprehensive analysis of the breakdown of that 6.6% rather than just assuming it's all due to social economic.
Sorry, so if you have a look at the first line towards the end of the second line, so I said
partially.
Partially.
Okay,
we believe
good.
that part of it, not for sure, because you can assume for sure that Netcare has built more new hospitals,
Anyway, but I think maybe just to step back, I think it's a challenge to the profession, because I think we've all been in meetings where we present risk-adjusted figures, and hospitals say, well, it's all well and good, but you haven't adjusted for socioeconomic factors, and we have a catchment area that goes beyond and into rural regions, and you haven't adjusted for that and for the circumstances of the patient, etc., etc. So I do think that it is something that we need to pay more attention to and build into our models. And what we did recently is we actually started a process of engaging with mental health facilities and looking at and trying to understand what's happening at those facilities. And it was very informative to find out what's happening on the ground in terms of the profile of patients that are attending, the supply versus demand factors. And the one facility we visited was very close to various informal settlements, and the catchment area. You have to take into account the catchment area. Obviously, we're dealing with scheme members, but it certainly was impacting, and they had a high a high incidence of substance abuse, which was affecting the mental health admissions. And so it kind of, once you start delving into the complexities of what's happening at a facility, it does explain some of the utilization patterns we're seeing. So I guess my question is, what did you do any research on the ground? Did you speak to the facilities? Did you speak to the providers? Did the psychiatrists, psychologists understand what's happening? And maybe that's a question to us as a profession. Do we fully understand the nature of the risk?
Thank you for the comment and question. And the short answer is no, I didn't speak to anybody in the ground. This is just purely based on sort of like data that we have in our database, and also desktop research that's aligned to the study, you know? Thank you.
Hi, thank you for the presentation, Jacob. I think my point mainly, I would say, almost links to Sarah. We work together. So on my side, I always find it very difficult, I think, when we speak about access to healthcare, right? Because I think, especially when you go to the rural I think, areas, because their access for me to healthcare, I would broaden it. Because if I look at like the cultural element in terms of how strong they are, in terms of like, I think the idea of speaking to your pastor, speaking to your traditional healer, which is actually missing here, in my own opinion. And of course, it's missing because of the limitations of data. It becomes very, very tricky, especially when we're going to say, I think, is it mental health prevalent? It's actually increasing. Because again, when you compare urban and rural, for me, especially, I'm from the township, so also our access to healthcare is defined very, very differently. I think that is just the point. And then the second one is more something I would really like to see, especially in these kind of presentations, where we actually include with the trends that we see in terms of like suicide rates, especially with men, when we say like women tend to seek more care, then what happens to males, right? How does it show up? So it's something that will be very interesting for me to see, I think, in the next presentation.
Thank you.
Sorry, unfortunately, we don't have time for any more questions, so I'll ask you to engage with Jacob there afterwards. But please note, we are now entering a 15-minute transfer time. So please do go to the next concurrent session that you want to attend. Just noting that please don't go in if the door is closed, because they may still be finishing up. Thank you very much.